This is Dr. Amy Ho, host of ACEP Nowcast. Before today's episode, we want to remind our listeners that registration for ACEP's 2026 Scientific Assembly is now open. Your specialty, your people, one place. Join us in Chicago this October and register now at acep.org/ACEP26 for free access to ACEP anytime.
So while you're documenting on your shift, somebody runs into the doc pod and says, "Doc, we have a pediatric drowning. Come real quick." And you run over and you wonder, what does this mean and what am I supposed to do?
EMS brings in your next patient, which is a 21-year-old man with hemophilia who fell off his bike. And you wondered, do I have to do anything differently for him because of his hemophilia?
In this episode of Critical Decisions in Emergency Medicine, we will talk about pediatric drowning, specifically its identification and management.
We will also talk about acute coagulation disorders in its identification and its management.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices in Florida and all over the world.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the July 2026 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss 2 lessons that are bread and butter emergency medicine or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features, such as the critical ECG, the critical procedure, and lots of tidbits from our drug and tox boxes.
And for our first lesson of this issue, we have Call for Blood, Acute Coagulation Disorders. Thank you to Doctors Erin Hogue, Arvind Jandoria, Trishna Dave, and Bernard Lopez for writing this article. You know, Wendy, when patients come in bleeding with abnormal coagulation tests, it can be challenging to determine what is the cause, especially when we have limited history. How should we approach these patients?
That's very true, Danya. We don't really have time to pull up the whole coagulation cascade to figure out where exactly the problem is. But I think if you break it down and think about what is normal hemostasis, we're talking about proper functioning platelets, of course, a normal coagulation pathway, as well as a normal balance in terms of fibrinolysis. And so when we are dealing with some sort of a bleeding disorder, coagulation problem, this can be caused by drugs, it can be caused by liver or kidney disease, it can even be caused by malnutrition, and also some congenital defects. I think our role in the ED, though, really is to try and figure out, do we need to act immediately, or do we have time to do some further evaluation to kind of pinpoint it?
Well, I'm not sure what you're talking about, Wendy. I totally have time to pull up the coagulation cascade during my shift. But just in case you don't, what are some coagulopathies that we may encounter in the ED?
I bet it's like your screensaver or something like that, right?
Thanks, Wendy, thanks.
Or maybe a rotating screensaver, a different disease process a week, who knows? Anyhow, obviously not an all-inclusive list, but a few things that we should think about when we have somebody coming in bleeding are disseminated intravascular coagulation, which is DIC, hemophilia, von Willebrand disease, as well as the common coagulopathies that we all encounter now because of the medications that patients are on intentionally, making them more prone to bleeding. And so specifically, though, breaking each of those down some, and when we're talking about DIC, we're talking about really formation of microvascular clots, and then that leads to a consumptive reduction in clotting factors and platelets. And really, if we're dealing with this condition, then we're really focused on addressing the underlying cause, which may be sepsis, trauma, certain cancers. If we're dealing with hemophilia, as you may remember, this is a genetic hereditary disorder. It's a sex-linked recessive disorder, so it typically affects men. And there's 2 types. There is a factor 8 deficiency and a factor 9 deficiency. And normally in all of us, with normal hemostasis, we need at least 25% of factors to be able to clot appropriately. And so when you are dealing with a patient with hemophilia, they can have as low as 5% or even less in terms of the severity of disease. And when we are trying to treat that, we're really talking about replacing those factors. When we're dealing with von Willebrand disease, this is actually the most commonly inherited disorder of hemostasis. While it's not really a coagulation factor deficiency, and rather a dysfunction in terms of platelet adhesion, because that's how von Willebrand factor helps platelets become more sticky. And so in this particular condition, we're dealing with decreased quantity or activity of this von Willebrand factor. And then, as I mentioned, we're very familiar with things like warfarin or direct oral anticoagulants and patients being on those and coming in with essentially a coagulopathy.
That's such a great summary for quite a lot of the bleeding disorders that we see. So let's kind of put it all together. What tests should we obtain if we are concerned about a bleeding disorder?
I think we generally think about, of course, getting a CBC and standard coagulation tests like PT and INR and PTT. But if you are specifically worried about one of these other bleeding disorders that we just mentioned, specifically for DIC, we want to measure fibrinogen level. Because of the fibrinolysis that's happening, that you're going to have a decreased fibrinogen level. And if we're suspecting hemophilia or von Willebrand disease, then we may actually have to get some additional tests like bleeding time, a peripheral smear, or even a von Willebrand factor antigen. That can definitely be helpful in making a diagnosis, but they may not, of course, be readily available to us in the ED in terms of turnaround times.
Makes sense. So now that we've identified a bleeding disorder, how can we actually manage it?
So I mentioned this already a little bit, but a little bit more detail on how specifically to manage each of these disorders. As I mentioned, hemophilia, these are patients who are deficient in their clotting factor. And so we're going to replace those clotting factors depending on what symptoms they're presenting with. And so if they're coming in just with minor bleeding, that may not actually require particular treatment. But more commonly, we're worried about things like moderate bleeding or episodes, which includes hemarthrosis. And that does require prompt replacement of factor because hemarthrosis can cause permanent joint damage if they're not treated in a timely fashion. In terms of more severe bleeding, like GI bleeding or intracranial bleeding, even patients presenting with head trauma, we have to presume that they could have an intracranial bleed. And so we actually have to treat these patients with immediate factor replacement even before really pursuing maybe the diagnostic tests to confirm, which is the CT scan. If you have any questions, consult with their hematologist, and patients and families generally are pretty familiar with what factors they need and how much. But just remember that this should be really replacing adequate factors so that they can clot appropriately, and that should be a weight-based calculation. Sometimes we even need to give additional other medications to help, which we have lots of experience with, like antifibrinolytics such as TXA or aminoglypuric acid, and that's oftentimes helpful if you have ongoing prolonged bleeding from the mucosal oral cavity. In terms for von Willebrand factor, it really depends on the type. So in type 1 von Willebrand disease, we're going to give desmopressin. And then in type 2 and 3, then these patients are actually going to need a combinational treatment with von Willebrand factor and factor 8. You can also use cryoprecipitate in life-threatening bleeds if you don't have this special combination of concentration available. Once again, if you have pretty severe bleeding, antifibrinolytics can also be really helpful. And we have lots of experience with drug-related coagulopathies like warfarin and direct oral anticoagulants. And so that might require vitamin K, FFP, or PCC in the case of warfarin, or in DOACs, then we're generally talking about PCCs.
Well, that's a great review of a broad range of treatments for bleeding disorders. Now, do we have to admit all these patients?
Not necessarily. Patients with hemophilia, if they have mild or minor bleeding episodes, they can be safely discharged with follow-up with their primary care or hematologist. And most patients with von Willebrand disease, if they're again coming in with mild, moderate type of bleeding events that are controlled, they can also be safely discharged. Even patients who are coming in with, let's say, just elevated INR in the setting of warfarin use or very minor bleeding that can be controlled in the ED, those could also be discharged. And so certainly it really depends on their severity.
Well, thank you, Wendy, for taking the time to go through these bleeding disorders. Such great reminders of quite a scary condition or group of conditions once we're faced with in the emergency department can just really get out of control if they go unnoticed or untreated. We talked about DIC, we talked about hemophilia, mostly the inherited part, the von Willebrand disease, and then coagulopathy that's induced by either warfarin or the DOACs, the direct oral anticoagulants. So thank you again for taking the time to review that. A lot of great pearls in this article. Moving on to our next segment, we have the critical ECG, where we talk about right ventricular-paced rhythms, where you have widening of the QRS complex, large R waves in leads 1 AVL, and then you can see pacer spikes in most leads. And similar to left bundle branch block, the presence of this pattern can obscure early ECG evidence of acute myocardial infarction, or, on the other hand, mimic the findings of a STEMI and make it quite confusing. And that's why the modified Scarboza criteria are quite important to know and review. So take a look at this article. For our clinical pediatrics, we have a teen with a spreading rash, and this is one of the cases where a picture is worth 1,000 words.
Yeah, it's a case of a 15-year-old boy who has a history of eczema, who comes in with a worsening vesicular rash on his face. And the rash is quite extensive. As Danya mentioned, take a look at the pictures. It was initially treated as impetigo, but that was unsuccessful. And then there was this actually spread from the lower face, the hairline, and even a lesion on his thumb. And so this is actually a case of eczema herpeticum, which can occur when the eczema lesions become secondarily infected by herpes, and it is actually a dermatologic emergency. Risk factors for this include young age, early onset of atopic dermatitis, non-white race, and poorly treated or severe atopic dermatitis. And there are also other complications we have to be aware of, such as when it involves the oral mucosa and causes gingival stomatitis, or ocular involvement causing keratoconjunctivitis, and even CNS spread with meningoencephalitis. In terms of treatment, we're talking about acyclovir, which requires 5 times a day dosing, and the duration would be for 1 to 2 weeks. Sometimes it is hard to, of course, for any patient and families to keep up with 5 times a day treatment regimen. So another option would be valacyclovir. If you are dealing with any sort of superinfection with a bacterial infection such as Staph aureus, then you should also cover with cephalexin. Topical steroids, though, is actually safe to use. And if you're dealing with a very severe infection, then you should even consider hospital admission.
Great review for a quite extensive looking rash. Again, you should totally look at that. Moving on to our literature review, talking about the article by Magnet et al. Entitled Extracorporeal Cardiopulmonary Resuscitation, Outcomes Improve with Center Experience, that was published in Annals in 2025.
We generally think about extracorporeal CPR or ECPR really at specialized quaternary care centers, because obviously it's not a resource that's readily available everywhere. But I think there are some interesting points from this article that we can all take away from. And so this particular study looked at essentially how to improve out-of-hospital cardiac arrest care with ECPR protocols through a partnership with EMS and other key stakeholders. And they started with a very standardized pre-hospital selection criteria, as well as protocols for communication between EMS and the emergency department, and then also a component of multidisciplinary simulation training. And that really helped improve their cannulation times, and they even saw improved outcomes during the study period from 15% favorable neurological outcomes to 37%, which is quite remarkable. And following that, they also created, like I mentioned, a standardized protocol where the EMS system would actually notify both the local as well as the ECPR center of patients, who are undergoing ACLS resuscitation. And when the patient arrived to the ED, after the physicians cannulated them for potential ECMO, they even did a transesophageal echo to really figure out if they're the right candidates, as well as ultimately, again, having a protocolized way with your feedback and ongoing training. And all of this really showed that they improved, again, their outcomes. And so while we may not all have access to ECPR at our centers, what I took away from this is really standardized protocols, multidisciplinary training, and a continual feedback and improvement process that can improve all types of care we do in AD.
Great review of a great article. So moving on to our critical procedure this month, it's the stellate ganglion block, which is to manage refractory ventricular dysrhythmia, which sounds quite dramatic and scary. But then again, if you look at the pictures of the actual block, that looks equivalently dramatic and scary. Other ways to use that stellate ganglion block, but hopefully not in the emergency department, is to treat pain or vasodilation in the upper extremity and to treat post-traumatic stress disorders. The block should be performed on the left side of the neck because it tends to be associated with fewer hemodynamic effects and a lower rate of complication. And just like pretty much everything we talk about these days, there's a blind technique and an ultrasound-guided technique.
Danya, have you done one of these before?
No. I looked at the picture and I was horrified. So you know when you watch movies and then somebody stabs somebody in the neck with a needle so they can pass out and then kidnap them? That's literally what this looked like.
Maybe that's what they were trying to do.
I don't know. Maybe those were all educational videos for stellate ganglion blocks. We were just missing it.
Yeah. For those who may not be as familiar with this technique, which I have heard about it, but yeah, going through the steps and learning about it, definitely take a look at the pictures, because when you are doing an ultrasound-guided technique, you have the patient's head turned to increase exposure to the side you're accessing. Certainly, you're using your ultrasound probe to try and identify the area deep to the carotid artery where you're trying to stick your needle to provide the actual block. And so it's essentially a lateral injection into the neck to do the block. And if you're doing the blind technique, then you have the patient's head positioned straight forward, and you're trying to palpate the C6 tubercle or transverse process, which I don't normally think about palpating the vertebrae anteriorly, so I think you have to palpate quite deeply. And then you're going to try and move the sternocleidomastoid muscle, and then again insert the needle and try and inject to perform your block.
And although it's not actually mentioned in the article itself, I'm really assuming that you're not actually looking for it on both sides at the same time and squishing the neck on both sides. But hey, what do I know? Moving on to our critical cases in orthopedics and trauma, we have a 24-year-old woman with a history of seizure disorder and recurrent right shoulder dislocations presenting with right shoulder pain and deformity. So when you look at the patient, the deltoid of the right upper extremity appears flat and the extremity is held in slight abduction. And the X-ray shows an anterior shoulder dislocation with a Hill-Sachs deformity. While shoulder dislocations are quite common, the glenohumeral joint is the most commonly dislocated joint. And usually patients with anterior shoulder dislocations hold the affected extremity in slight abduction and external rotation. And there's a loss of the normal deltoid contour, giving the shoulder a squared off appearance. In order for us to see that properly and clearly on x-rays, we need an AP view, a scapular Y view, and an axillary view, which sometimes can be a little challenging getting in these patients. Just like pretty much everything we talk about, point-of-care ultrasound has recently emerged as a powerful imaging adjunct, especially to confirm the reduction. In some patients, that can be challenging to tell clinically, and you really don't want to be stopping. There's sedation involved. It's a whole thing. So maybe just have that ultrasound there to help you in real time. As for facilitating the procedure, intra-articular lidocaine has similar reduction success rates, fewer adverse events, and shorter emergency department stays than procedural sedation. Another option would be ultrasound-guided regional anesthesia, like the intrascalene brachial plexus block. And Wendy, I'm sure you remember, we've talked about this extensively during one of our earlier podcasts a couple of years ago, where we went into the details of all of these upper limb blocks. Now, at the end of the day, the best technique is the one that the physician can perform reliably while minimizing patient distress when we're talking about how to physically reduce that dislocation. So there people talk about the ferrous, the this, the that. The one that you can do is the best one, except for the one with the foot and the armpit thing. Like, that is not the best one. Do not do that. So moving on to our critical image this month, finally pickleball makes an appearance on our critical images.
I'm going to have to know. Are you playing pickleball?
No.
Wait. I thought we've always taken a stance of not doing dangerous activities, which clearly this is a dangerous activity and its feature in critical decisions.
So apparently this person comes in with a severe left posterior ankle pain. He's unable to plantar flex the ankle. The Thompson test is abnormal, the one with the calf squeeze, but you do see a little bit of a weak plantar flexion. And then they do a pocus of the Achilles tendon.
And you found an Achilles tendon rupture. See? Quite dangerous. As we remember, usually when we're dealing with Achilles tendon ruptures, it's classically associated with a sudden, forceful ankle plantar flexion, which you do in playing pickleball. Unfortunately, up to 30% of cases are missed on initial evaluations, and that's associated with often litigation claims and, of course, worse outcomes due to the delayed diagnosis and treatment. And so the use of ultrasound is also great in evaluating this because by using a linear transducer, you can follow along the longitudinal plane of the Achilles tendon, and you're looking for any sort of partial or complete discontinuity of the tendon. You can even see a hematoma and a posterior acoustic shadowing from where you normally should see the tendon. And the other thing that is quite interesting is you can do it in real time with your Thompson test.
That sounds pretty cool. So for our second lesson of this issue, we have staying afloat, managing pediatric drowning. Thank you to Doctors A.J. Graham, Allison Visath, and Prianka Kandhal for writing this article. And I am grateful to have the senior author with us today. With us is Dr. Prianka Kandhal. Welcome to today's episode. This is certainly a timely topic, especially during the summer months when we see an increased exposure to pools and other bodies of water.
Thanks, Danya and Wendy. It's great to be here.
Great to have you. So, Priyanka, what prompted you to write about this topic?
Well, I live in practice in South Texas, and most of my patients have swimming pools or ready access to water.
Such great reasons to write about an important topic. But first things first, what do we mean when we say drowning?
So we're really talking about a clinical diagnosis that is seen after a patient has a history of submersion or immersion in liquid and associated respiratory impairment. We really want to avoid terms such as near drowning, dry drowning, secondary drowning, or silent drowning because they end up leading to confusion both with patients and families and with clinicians.
That's definitely an important clarification. Are there any historical elements that we should obtain in a patient presenting with drowning?
I think the biggest thing is exactly what happened. How long do we think the child was underwater, if it was witnessed, whether there was any bystander CPR, or whether that was by a trained professional or by family at bedside, and what the child's status was immediately after rescue.
So how about the physical exam? Any pearls there?
Similar to all of our critical patients, ABCs first, so making sure that we're securing the airway, especially in these kiddos, and making sure that they are being ventilated appropriately. We're going to be looking for evidence of pulmonary injury. So in children, we care much more about their work of breathing than their oxygen saturation. Children will typically have increased work of breathing and tachypnea before they start desatting. So even if they're satting okay, we want to pay attention to whether they have intercostal or subcostal retractions, suprasternal retractions, or tracheal tugging, nasal flaring, especially in younger children. So we're watching their respiratory status. And then we're going to want to do serial exams because their respiratory status can be evolving and they can initially look okay, but then progress over the course of their ED stay.
Got it. Now, with some of these respiratory symptoms, do we need to get any imaging?
Most people will get chest x-rays, but they have limited diagnostic utility. The patient's clinical status and respiratory status is far more important. Kids can have normal chest x-rays and still require admission, and some kids with abnormal chest x-rays can look very well-appearing and maintain after a period of observation. So although probably you'll obtain a chest x-ray, the clinical assessment is more important.
All right. Well, given that the chest x-ray is not necessarily that great, but rather an adjunct, what other images can we think of as being helpful in these patients?
You can definitely do point-of-care ultrasound of the lungs to look for signs of pulmonary edema, which can sometimes be a little bit better than chest x-ray at catching subtle signs of pulmonary edema. For the most part, we don't really need any neuroimaging because most patients will not have any anoxic brain injury that's visible that quickly. And so that will be more of a prognostic factor later on when the patient is admitted if they have degrees of hypoxic injury. But of course, if you have signs of trauma associated with the submersion incident, then you will want to appropriately image based on whatever type of trauma they had.
Great reminder as well, and a great pearl. When should we suspect other serious injuries when treating pediatric drowning patients?
I think of things like prolonged submersion time, delayed rescue, whether they needed some sort of CPR, if they had a prolonged resuscitation, especially once EMS arrived, and if they persistently are altered after the rescue. Those are all poor prognostic factors. The clinical appearance with significant work of breathing or lack of work of breathing, and then some lab abnormalities can guide you, such as a severe metabolic acidosis or elevated lactate, but those are going to be more after you have major clinical assessment, and they might correlate with significant hypoxic injury.
What type of respiratory and hemodynamic support should physicians consider for pediatric drowning patients?
First and foremost, we want to correct hypoxia. So in an alert child who looks well, we can start with nasal cannula and escalate potentially to high-flow nasal cannula. But for patients who have altered mental status, they may require endotracheal intubation or positive pressure ventilation. Children don't tend to tolerate BiPAP and CPAP as well as adults. So depending on the age of the child, this might be something that intubating is the best way to deliver positive pressure ventilation if it's really needed, or they might need some sedation to tolerate something like a RAM cannula. But ventilatory support is the first priority. If they have some circulatory dysfunction or shock, then we want to start with fluids, but escalate to pressors as needed if they develop cardiogenic shock. If you have access to ECMO or can transfer for ECMO, patients who are critically ill may have a good response to ECMO.
That makes sense. Are there other treatment adjuncts that we should consider as well?
There's not really a role for routine use of steroids or antibiotics, but many of these patients will come in hypothermic, so that's an important thing to consider. We want to make sure that we're obtaining a core temperature during their initial evaluation and rewarming. If they're substantially low, you might do some active rewarming, otherwise passive rewarming, warmed fluids, warm blankets, take off the wet clothes. Unless you have any sort of story that's very concerning for C-spine injury, we don't really need to do C-spine immobilization. But of course, in a diving injury, we want to make sure we're immobilizing the C-spine until we're able to stabilize an image.
Such great pearls on managing drowning patients who are quite sick. But what about the well-appearing child who comes in after a drowning incident? How do we manage those? When can we discharge them?
That's a great question. I think the biggest pitfall is discharging a well-appearing child too soon, because sometimes their status can evolve over the course of about 6 to 8 hours. So a well-appearing child who is not requiring any respiratory support, does not have any increased work of breathing, can typically be discharged after around 6 hours if they are continuing to have good oxygen saturations and a normal lung exam. There is a score called the Pediatric Submersion Score, which can identify children who are at low risk for significant injury. It basically looks at their mentation, their dyspnea, respiratory rate, systolic blood pressure, and whether they're requiring respiratory support. So all things that you would otherwise also be evaluating. But in a child who is looking well, If they continue to look well after about 6 hours, then they are safe to discharge.
That's very helpful. Now, what about generally reducing risk on drowning? How can we as physicians identify opportunities to counsel patients and families for at-risk patients?
I like to break things down by age. So big things are remembering that pre-ambulatory children, I'm thinking around a year or under, are going to be at risk for drowning in the bathtub and at home and should never, ever be left unattended near any sort of water, a bucket. It's usually not a lot of water, and those children can drown in very little water. For toddlers, it's frequently a supervision issue and insufficient barriers to access. So for toddlers, I think about pool fencing, having a designated water watcher at any sort of family event where there is a pool nearby or anything like that. In a lot of ways, when there are a lot of adults around, there's a diffusion of responsibility and everyone assumes that someone is paying attention. So no one is paying sufficient attention. So I really like having a designated water watcher who takes a shift where they are the only person who is paying full attention to whatever body of water is nearby and any children nearby. And then you do your half an hour of being designated water watcher, and then it's someone else's turn, and then you can relax and know that someone is paying attention. And a verbal handoff of, okay, I need to go to the bathroom. You need to be watching the water and kind of making sure that you have closed loop communication related to who is responsible for watching the water. CPR training is always great. It's not preventative, but it does improve a child's likelihood of survival if they get early CPR in a severe drowning incident. And then just general counseling on swim lessons, pool fences, and appropriate flotation devices on open water.
Thank you. Those are some really great strategies that I'm going to take home with me. This was a great discussion. What would you like to leave our listeners with?
I think the biggest things are to remember not to use terms like near drowning or dry drowning. Just stick to regular, plain old drowning, and to focus on respiratory support early and circulatory support as needed, but focusing on early respiratory support and positive pressure ventilation, avoiding adjuncts like steroids and antibiotics as they don't have a role in the acute setting. And then for your well-appearing children, making sure you observe them for a period of about 6 to 8 hours to make sure that their respiratory status doesn't progress, requiring further intervention later on. And then most importantly, using these opportunities in the emergency department to counsel families on what they can do to prevent future drowning incidents.
Prianka, thank you so much for taking the time to join us and, more importantly, to write this article with your team. It has been incredibly helpful, a great refresher on an important topic, and hopefully we will get to see you soon on another podcast.
It was a pleasure to be here. Thank you so much.
So for our drug bucks this month, levetiracetam. Is that the most popular drug in the neuro ICU, Wendy?
Absolutely. I mean, it's a broad spectrum anti-seizure medication. There's generally not too much adverse effects that we have to pay attention to, but certainly there are some neuropsychiatric side effects, most commonly related with drug discontinuation. And so we do have to pay attention to maybe things like suicidal ideation in the ED. And then there is a rare but life-threatening condition called DRESS, which is the drug reaction with eosinophilia and systemic symptoms. But it's an easy medication to give because there's similar IV and oral bioavailability. And so in terms of dosing, we're talking about in status epilepticus, 40 to 60 milligrams per kilogram. And then generally maintenance doses that ranges from 1,000 to 3,000 milligrams per day in divided doses.
Great reminder about the weight-based dosing for levetiracetam. So last but not least, selenium toxicity. Selenium is an essential trace element that is widely used in industrial processes, such as xerography and photography. With acute toxicity, you have GI, neuromuscular, and potentially lethal cardiovascular manifestations. Chronic toxicity, on the other hand, is more integumentary and neuropsychiatric manifestations. Death is reported with ingestions of more than 10 milligram per kilo of selenious acid or more than 66 milligram per kilo of sodium selenite. If you are concerned about this, because of a really good history of selenium, because otherwise I'm not sure how I would think about it, then you need to obtain whole blood selenium levels for that chronic exposure. But then for the acute exposure, it would be serum or urine selenium levels, and then ECG, thyroid-stimulating hormone levels, and acetaminophen level. For management and treatment, decontamination is the first thing with acute issues, and then supportive care because there are no real antidotes or enhanced elimination methods.
Interesting indeed.
Well, thank you, Wendy, for taking the time to go through this issue with me. I learned a lot. Our dear listeners, we hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decisions publication, as well as our podcast, always informative, often enlightening, and never boring.
Reach out to us on our social media. My handle at Instagram is at Dr. Danya Khoujah.
Mine is at Dr. Wendy Chang.
And until next month,
Bye-bye.